Welcome, intellectuals, to another class with MMG. Yes, today we discuss another question of the 2022 tutorial sheet, question E, dealing with antifungal agents. The class of antifungal agents we look at is polyene antifungals. So we'll look at some questionnaires. Okay, so the above question reads, Mr. HB, 45-year-old patient, presents to the outpatient department, cautions. Diagnosis of cryptococcal meningitis is made, and you're the attending pharmacist. You're required to make a recommendation of the drug. You have the following drugs in your pharmacy. So drugs A, drug A is present in your pharmacy. Drug A is the above drug, okay, and drug B. So both drug A and drug B are present in your pharmacy. Okay, now let's look at the questions that follow. Which drug would you recommend for systemic treatment? Okay, so for Mr. HB's systemic treatment, between the two drugs, we would recommend, first of all, these are polyene antibiotics. So we would want to consider the polyene component, and from the analysis here, we would consider drug A as the recommended drug for the systemic treatment. Explain from a structural point of view the reason for your answer above. So the structural reason behind the answer is the double bonds on drug A. So drug A has a total number of 1, 2, 3, 4, 5, 6, 7 double bonds. Okay, that is more double bonds as compared to drug B. So with regards to polyenes, the more the number of double bonds, the safer the drug. So drug B has 1, 2, 3, 4, 5, 6. So it has one double bond less than drug A. So this qualifies drug A to be used for systemic treatment. Okay. Then, the polyene component on drug A, as we've explained, has 7 double bonds, while drug B has 6. Therefore, the more double bonds on the polyene component, the safer the drug and the more activity the drug has. Okay, that should be a good enough reason there to support our judgment. Okay, let's look at B. Using a structure-activity relationship, we are required to justify our decision in A. So using the structure-activity relationship, why did we choose drug A? So for polyene class of drugs, okay, polyene class of drugs, so this class of drugs where drug A and drug B belong, okay, the polyene component, which is the double bond, the long chain double bonded carbon-carbon chain, is having a number of double bonds, and these number of double bonds are directly proportional to the safety and the activity of the drug. Okay, so the polyene component is the highlighted component in the drug. So how many double bonds are present in the drug is directly related to the activity and the safety of the drug. So using the structure-activity relationship, will elucidate the fact that for polyene antifungals, the number of double bonds is directly proportional to the safety, okay, and the activity of the drug. And we can conclude to say that, okay, the more the double bonds, the more affinity the drug has to ergosterol as compared to cholesterol, because of its hydrophobic nature. Okay, so that is our structure-activity relationship as elucidated on B there. For the polyene class of drugs, the number of double bonds is directly proportional to the activity of the drug. Therefore, the more the drug has the double bonds, the more the selectivity for ergosterol than for cholesterol. So this reduces toxicity, because as we know it, in the human membranes, cholesterol is present. So interaction with cholesterol might lead to adverse reactions. So further, Mr. HB was on first-line treatment of ART for 3 years. Then genotype resistant testing shows the following thymidine analog mutations, or so-called TAMs: K65R, M184V, and K103N was also shown. Okay, so the questions read, they explain the notation TAM. Of course, these are thymidine analog mutations. Yes, they are associated with nitrogenous base thymidine, so they all have an effect on various amino acids and mutations. Examples: K65R and M184V, of course. Okay, and then they want to see the impact that the thymidine analog mutations have on Mr. HB's regimen. So the individual point mutations will have the following implications. So for K65R mutation, it will reduce susceptibility of the reverse transcriptase enzyme to tenofovir or TDF in the above regimen. So this leads to reduced activity. So for K65R, we expect tenofovir's activity to reduce in the presence of such a mutation. Secondly, for M184V, this will result in reduced susceptibility to lamivudine 3-TC. Therefore, we'll have reduced activity of the drug as well. So such genetic change can cause a reduction in the susceptibility to 3-TC, and that is M184V mutation. For K103N, this will result in reduced susceptibility to efavirenz, which is present in the regimen that Mr. HB is taking, okay, on the current regimen. Yes, so this reduced susceptibility will lead to reduced activity of efavirenz. Okay, and further, D asks us to write about the implication that K103N has on the treatment or the ART regimen of Mr. HB. So for K103N, this will mean a reduced activity of efavirenz. Okay, so on the current regimen, efavirenz activity will have to reduce because the binding potential of efavirenz is compromised by the replacement of lysine, because lysine has more affinity for efavirenz. So when we replace lysine, the binding affinity to efavirenz is drastically reduced. Okay, of course, the reduced susceptibility is more in nevirapine, but there is a more of a justifiable amount of resistance towards efavirenz in this type of mutation as well. So we expect a reduced activity of efavirenz in K103N mutation. That is our clinical implication. Thank you very much for this short period. Shalom.